So now we're going to start talking about the hip in Chapter 9. So you will probably notice that we skipped over Chapter 4 through 8 and went right to Chapter 9. And the reason that we're doing that is we've talked a lot about the different times that the different people that teach kinesiology, sort of the right order to do things in. And we have found that this order works really well. So we do sort of the preliminary chapters, then we do lower extremity, and then we go to the upper extremity, and then we go to the spine. So we're going to start at the hip and work our way down to the foot, and then we will go back up to the shoulder and work our way down to the hand, and then we'll work on the axial skeleton. So for all of the remaining chapters that we work on this quarter, we are sort of going to have a similar pattern. In that, we will talk about the osteology, we will talk about the ligaments involved in the individual joints, we will talk about all the different muscles involved in the joint, and then sort of functional things about each joint. So hopefully you will get used to that pattern. It will make sense to you. However, you do want to mix things up so you can sort of integrate the information. So I'm going to start talking in this part of the lecture about the osteology of the hip. And there are all sorts of great pictures in the book and all that. However, they're two-dimensional, and really there's no substitute for getting your hands on some bony models and finding these bony landmarks, and then getting your hands on a human being and finding the palpable landmarks on a human being. Because it's one thing to know it, it's another to be able to find it on a person. And in physical therapy, we have to find it on a person. These are our landmarks. These are our roadmap for finding things. So I always say you can't treat an injury if you can't find where it is. So part of the reason that we study the osteology is so we can find stuff on people. That totally makes sense, right? So when we're talking about the hip joint, it's the articulation between the head of the femur and the acetabulum of the pelvis, basically. So the hip bone, if you want to call it that, also known as the os coxa or the innominate bone, it's really three fused bones: the ilium, the ischium, and the pubis. It's irregularly shaped, as you can see, and those bones are fused by adulthood. When we're children, our bones are a little softer, they have a little more cartilage, but the bones fully fuse by the time we're adults. And the femur is the long bone of the upper part of our leg. So we're going to talk about landmarks on all of those things, and then we're going to look at them on bony models in the lab, and we're going to palpate the palpable ones on each other. So in the lab practical, which we don't have our first lab practical until the lab weekend in May, but part of the lab practical is going to be identifying bony landmarks on those bony models, and the second part of it is going to be palpating bony landmarks on a person. So you have to be able to do both. So we're just going to start right into it. So the ilium is the wing-shaped superior portion of the innominate. Innominate means unnamed, which I think is interesting that they call it that, but it's just like, oh, there are too many things in here, we're just going to call it this. I don't know who came up with that, but the ilium is the top part. And the iliac crest, you can palpate it on yourself right now if you want to. It's the long ridge of bone that marks the superior border of the ilium. A lot of times when we have a long ridge of bone, it is an attachment for muscles. So when you see the pictures in the book, like this one right here, the sort of pink parts on there are muscle attachments. And they have it written on there which muscle attaches where. So the anterior superior iliac spine is the anterior tip of the iliac crest. So if you're palpating your iliac crest right now, or somebody else's, you can run your fingers down anteriorly on the iliac crest until you find where it starts to turn the corner. Where that corner is, that's the ASIS, anterior superior iliac spine. The anterior inferior iliac spine is just inferior to the ASIS, and it's the proximal attachment for the rectus femoris. It is a little bit more difficult to palpate just because there are muscles and things in the way. It is palpable, but it's a little bit more difficult to palpate than the ASIS. And the more padding that you have, the more difficult it is to palpate bony landmarks. So we'll practice, and it'll be fun. But no matter how much you practice, you'll still find that person in the clinic that you cannot find a bony landmark on to save your life, and then you're going to do your best. So if we start at the top of the iliac crest again and we move posteriorly, we will find where it starts to turn inferiorly, and that first corner is the posterior superior iliac spine. It's the posterior tip of the iliac crest. It is a little bit more difficult to palpate than the anterior superior iliac spine, just because there are more ligaments and tissues in the way. The posterior inferior iliac spine, or the PIIS, is a small bony prominence located inferior to the PSIS, and it marks the superior tip of the greater sciatic notch. And we will practice palpating these in lab. So the greater sciatic notch is not palpable on a human, but we will identify it on bony landmarks. It's the semicircular space between the PIIS and the ischial spine, and it provides space for the sciatic nerve to exit the pelvis. So the sciatic nerve is huge. It's one of the biggest, longest peripheral nerves in our body. It's about the thickness of your thumb, so it needs some space to get out there and go down the back of your leg. The sacrospinous and sacrotuberous ligaments sort of close the circle, and they convert the greater sciatic notch to the sciatic foramen. So they just close the end of that circle. The iliac fossa is the smooth, concave anterior surface of the ilium, and it's the proximal attachment of the iliacus muscle. So the ilium articulates with the sacrum, forming the sacroiliac joints, or the SI joints, we'll call them. So there's not a lot of movement in the SI joints, but there is movement. It's mostly stabilized by ligaments, and we will talk a lot more about that in your lower extremity orthopedics class and your manual therapy class. The ischium is the posterior inferior aspect of the innominate. The ischial spine is a posterior projection of bone that marks the inferior aspect of the greater sciatic notch. So it's sort of the pointiest part on the posterior pelvis. In this picture, it doesn't look all that pointy, but when you get your hands on some bony models, it's super pointy. The ischial spine cannot be palpated on a person, but of course we can find it on a bony model. In your lab manual, the bony landmarks are listed, and the ones that can be palpated on a person, which are therefore fair game for the practical, are in bold, and the ones that cannot be palpated on a person are not in bold. So if you can't palpate it on a person, expect to be able to find it on a bony model. If you can palpate it on a person, then it's fair game for the palpation part of the practical. So the ischial tuberosities, sometimes referred to in yoga and Pilates classes as your sit bones. It's the bumpy projection from the posterior inferior aspect of the ischium. It's the proximal attachment of the hamstring muscles. So if you're sitting down, you are probably sitting on them right now. They're palpable. You can palpate them on a human being. You can palpate them on yourself. So we sit on our ischial tuberosities. So people who lack normal sensation or can't do independent pressure relief are at risk for developing pressure ulcers. Anytime when you have a bony landmark that's getting a lot of weight on it, you can compress those tissues, and so seating is really important for people that can't relieve pressure on their own. The ischial ramus, a ramus is an arm, you can think of it that way. The ischial ramus extends anteriorly from the ischial tuberosity to join with the inferior pubic ramus. So the ischium has just one ramus. The pubis has inferior and superior. The pubis is composed of those two rami, superior pubic ramus and inferior pubic ramus, and they coalesce anteriorly to form the pubic crest. I like that word, it's kind of nice. So the superior and inferior rami of the pubis form that little point in the most anterior part of the pelvis that's called the pubic crest. The pubic symphysis is the junction between the pubic crests of each side, of each innominate, and it completes the anterior ring of the pelvis. So that pubic symphysis, that's one of those amphiarthrotic joints that has the fibrocartilage. It allows for a little bit of motion, and it resists compressive forces. So there's definitely motion in your pelvis when you're walking and when you're standing and things. And so that pubic symphysis is a shock absorber for that. The obturator foramen is the large circular opening formed by the pubic rami and the ischium. So it's covered by the obturator membrane, which serves as a proximal attachment for some of the deep hip rotator muscles, the obturator infernus and the obturator externus. So it is, even though it's a hole in a bone, it's covered by a membrane. The acetabulum is the cup-shaped structure enclosing the head of the femur, and it's formed by the combination of all three pelvic bones. I think there's a picture in the book. If it's not in this book, I think there's a picture in the Trail Guide to the Body where it kind of shows how each one has its little third of the acetabulum, the pubis, the ischium, and the ilium. The lunate surface of the acetabulum is the horseshoe-shaped superior surface that's lined with articular cartilage, and that is kind of the weight-bearing surface of our acetabulum, and it contacts the femoral head. The acetabular fossa is a depression deep within the floor of the acetabulum. So a fossa is always a depression. So there's a very tight joint between the head of the femur and the acetabulum, and it has to be, it's a big weight-bearing joint. It's one of the major weight-bearing joints of our body, and so the acetabulum itself is pretty deep. We also have a labrum, we'll talk about it in stabilizing structures, to really help stabilize that joint, and it's a significant amount of ligamentous support. So the femur, it's the longest bone in the body. The proximal femur is composed of a head, neck, and shaft. The femur head is the ball part of the ball and socket joint, and it contains a depression that's called the fovea, which accepts the ligamentum teres. So the ligamentum teres attaches from the fovea of the head of the femur into the acetabular fossa, and that helps stabilize the joint. The neck of the femur connects the head to the shaft, and it's bordered superior laterally by the greater trochanter. So the greater trochanter, easily palpable on a human being. It's a projection of bone that extends laterally from near the junction of the femoral neck and shaft. It's a distal attachment for a huge number of hip muscles. So one of our discussion board this week focuses on the greater trochanter. What attaches there? What's its clinical significance? Why do we care about the greater trochanter? We do. We care a lot about it. For one thing, it's a goniometry landmark for the stationary arm of our goniometer when we're measuring knee flexion, and for the axis of the goniometer when we're measuring hip flexion and extension. So it's one that's really easy to find, hopefully, and we will practice finding it in lab. So there's so many muscles that attach to it that we will talk about it one by one when we go in the muscle chapter. The lesser trochanter, it's a sharp posterior medial projection of bone on the other side, on the medial side of the femur, that's a distal attachment for the iliopsoas muscle. So a big important muscle, iliopsoas, it's one of our major hip flexors, and it has that big important attachment on the lesser trochanter. The Intertrochanteric Crest is a ridge of bone connecting the posterior aspects of greater and lesser trochanters. So on a bony model, you can really see that crest. It's on the posterior aspect. The intertrochanteric line courses anteriorly between the greater and lesser trochanter. It marks the distal attachment for the anterior hip capsule. On a bony landmark, it doesn't stick out like the crest does. It's almost an imaginary line between if you were to draw a line between the greater trochanter and the lesser trochanter on the anterior portion of the femur, but it is where the joint capsule attaches anteriorly. So the trochanteric fossa is a small pit on the posterior medial side of the greater trochanter, and a lot of the external hip rotators attach on or near that thing. The linea aspera is a slightly raised line that courses along the posterior side of the femur. And it's the distal attachment for a lot of the adductor muscles and the proximal attachment for two quadriceps muscles. So a lot of our hip and knee motions originate or insert on the linea aspera. So it's anytime when we have a big bony protrusion, there's usually a lot of muscles that attach to it. That is a general rule, and it makes sense. And if you read the little blurb on Wolff's Law, you can see why it makes sense. So anything you're pulling a lot on, the bone changes in response to the stresses you put on it. And so when you have a big protrusion on a bone, it means it's a place of attachment for a lot of big muscles. So the pectineal line is a small crest of bone. The linea aspera is a big crest. The pectineal line is a small crest running from the lesser trochanter to the superior aspect of the linea aspera. And it almost sort of makes a Y with the top of the linea aspera. When you look at the femur bone models, you'll see that. Of course, these aren't palpable because they're under all those big muscles. It's the distal attachment for the pectineus muscle, though. So it's interesting to note that the pectineus goes from the anterior part of the pubis to the posterior part of the femur. So that gives it a line of pull for a lot of different things, and we'll talk about that when we talk about the individual muscles. The gluteal tuberosity, it arises from the superior lateral portion of the linea aspera. So if you think of the pectineal line as one leg of the Y, and the gluteal tuberosity is the other leg of the Y, and then the linea aspera as the tail of the Y, you can sort of think of it that way. It's a distal attachment for the gluteus maximus. The gluteus maximus is huge and strong, and so it's going to be big. Big muscles have big bony attachments. The adductor tubercle, it's a raised portion of bone just proximal to the medial epicondyle, making a distal attachment for the adductor magnus. It's another huge muscle with a big bump on a bone that attaches to. This is a pattern that we are going to continue to see. So just talking about the bony arrangement of the femur, we're going to talk about two aspects of that. One is a frontal plane alignment, which is the angle of inclination, and one is a transverse plane alignment. So the angle of inclination, because the femur is not just dead straight, it actually takes a little turn into the neck and head portion. There is a frontal plane angle created between the femoral neck and the shaft of the femur. So for optimal hip alignment, the angle of inclination is about 125 degrees. So when we get in the lab, let's break out some femurs and measure their angle of inclination just for fun. You can't do that on a human being except by an X-ray, but some of the external manifestations of changes in angle of inclination you can observe on a human being. So the angle of inclination directs the shaft of the femur medially, and thereby it positions the knee joint directly under the weight of the body. So that's the whole point of having that angle is positioning of your lower extremities underneath the weight of your body. So if you have an angle of inclination that's significantly less than 125 degrees, it's called coxa vara. Coxa meaning hip, and I have to look up the Latin what vera means, but anyway, that's what it is, coxa vara. And if you have an angle of inclination that's significantly greater than 125 degrees, that's coxa valga. So as you can see, if you have the lesser angle of inclination, you have coxa vara, the shaft of the femur is going to have to change position in order to have congruency in the hip joint, as well with coxa valga, and how it changes varies with that angle. So we will play with some of the bony models in lab so you can kind of see the changes that it makes. So if you have coxa vara, the shaft of your femur is going to have to move medially in order for the head of the femur to articulate congruently with the acetabulum. If you have a greater angle, the shaft of the femur is going to have to move laterally. So basically, with coxa vara, you're going to end up kind of knock-kneed, and or genu valgum, it's called. We'll talk about that more when we get to the knee chapter. And with coxa valga, you're going to end up kind of bow-legged. So the angle of inclination changes the angle of the shaft of the femur in order to maintain joint congruency. So deviations in angle of inclination can occur from abnormal development in early childhood or from trauma. If you have some kind of hip injury, it can, and you break the neck of your femur and it can heal different, you can get deviations. So coxa valga, again, describes the angle of inclination significantly greater than 125 degrees, and that results in the bow-legged position. Coxa vara, angle of inclination less than 125 degrees, and that results in the knock-kneed position. So the angle of torsion it's the position of the head and neck of the femur in the transverse plane. So there's a natural twist along the femur's axis, and it's a little bit forward of the frontal plane, if that makes sense, in the transverse plane, the neck of the femur. So the femoral neck normally projects anteriorly about 15 degrees, and that's often referred to as normal anteversion, and it's the optimal alignment between the femoral head and the acetabulum. And again, that alignment is to get your knee joint aligned underneath your weight. Excessive anteversion may lead to anterior instability of the hip. If you have less than normal anteversion, it's referred to as retroversion. And again, that can cause a toeing in because it rotates the femur medially and causes that toed in position.